nothing we can do on this. We just have to zoom it. थोड़ा zoom कर सकता है पूरा maximum zoom में जाना. Yeah. Yes.
So you want me to start my talk, or you are going to be busy with that?
Did you hear that? Yeah, I don't think I've heard that.
Yeah, you tell me once you finish. No, once you say okay, go ahead. Yes.
Yeah, hold on. Let me try to contact Dr. Rilesh.
Hi, John, can you hear us? John?
Yes.
Dr. Satish Gore is here. He is one of the renowned endoscopic spine surgeon. He is here. John? Hello, John.
Yes.
Dr. Satish Gore is here. He wants to deliver a lecture.
Okay, let me just get the instructions of what to do from IPE or Dr. Nisula.
We are using the same instrument, the same login ID. You don't have to worry about anything. We are just transferring the same.
Okay, Dr. Nisla, who do you want to be the next speaker? Who's running the show there?
Dr. Satish Gore. Hello, John, can you hear us?
I still haven't heard from the IPE or Dr. Nisla.
Hello, this is Nilesh here.
Okay, what do you want to do?
Yeah, Dr. Satish Gore is here. He's an endoscopic spine surgeon. He wants to demonstrate his technique of the endoscopic spine surgery. So could we proceed now?
Thank you.
Okay. Now Gore will talk, sir. So please.
Okay, good morning. I am Dr. Satish Gore. I'm in practice for the last 37 years, out of which 20 years I have devoted to transforaminal endoscopy of the lumbar spine. Now, how many of you have seen, read, or assisted transforaminal spinal endoscopy? Yeah, probably very few, maybe. Okay, so I thought that I'll just give you a basic introductory thing and also the advanced thing. So you would know what exactly we are doing, why we are doing it that way. Okay, and there are a couple of questions which I always find that during our conferences are never answered. Why do you do this way? Or at the last day of the conference, every person would say that you should do this and you will get the best results when you choose your cases properly. And nobody tells you how to choose your case, correct? That has been my experience all these years. So what I thought is I'll just make you oriented to our thinking. The basic difference in what I do and what you people probably do is I do all my surgeries under local anesthesia through the foramen, and the cut on the skin is about 8 millimeters, so I don't have to stitch it back. So I call it as a stitchless surgery under local anesthesia. And I've been doing it for the last 20 years, out of which last 5 years we have been doing stenosis, and we have just, last year we have started talking about it because there were a lot of concepts to be developed and a lot of ideas to be clarified. So now I'm going to tell you basically everything about why, how, where, when, etc. So basically, what is degeneration? Because my talk is primarily related to degenerative lumbar spine. I'm not going to talk about red flags and yellow flags and brown flags and all that, because that is what is basically taken as understood. So we are looking at a phenomenon where the lumbar spine is changing. Now, commonly in our day-to-day practice, we mix this word degeneration with aging. And we say that, you know, your spine is aging. which in a way is a correct statement. But if you go academically and go at the cellular level, there is a difference. What is the difference? If you see a healthy spine, aging spine and degeneration, the main difference is in a degeneration, there is a structural failure. That is, there is a change in the structure, which is not normal change. It's a failure of that structure. And this structural failure gives rise to symptoms, whereas aging is asymptomatic. So that is the main difference. And why are we concerned about this change or this structural failure? Because that is what gets a neurovascular reaction or an inflammatory response, and that is what gives the symptoms. So theoretically, when a patient comes to you and says that I have pain in the back, you must immediately conclude that there is a structure in the back which has failed as compared to normal, and the body is reacting to that failure and giving rise to symptoms. So as a clinician, then it is your duty to find out where is this structural change, okay? And the second thing is, it basically is a combination of inflammation and compression. Not only compression, because all these years we have been talking about compression and decompression. It's not true. It also has an element of inflammation. And I can go to the extent of saying that about 80% of our patients who come to us in the OPD, who don't need surgery probably, are all having inflammatory part in their symptomatology. How do we detect that, etc.? I'll be talking a little bit about it. So please remember that the main distinction which we have between aging and degeneration is there is a structural failure which is absent in aging. What is the main feature of aging? It is reduced diffusion or reduced nutrition of the tissue. So it's like you have a plant in a pot and you forget to water it every day for say a month or so. At the end of the month, the plant will all shrivel up and will die. So same thing happens with the biological system. There is no nutrition, so the whole thing slowly stops. There are no symptoms. Now, this is a very simple diagram where on the left, you're looking at a coronal image of a functional spinal unit where you have a vertebral body, another vertebral body, dural sac, and the roots. And this is what you're looking at as a sagittal image, conceptually, schematically. Now here, please remember that when we are talking of this functional segment, let's say this is L4, this is L5. So these are pedicles of L4, these are pedicles of L5. This is the exiting nerve L4 going out below the pedicle. And then this is a disc between 4 and 5. This is the L5 root, which here is called as traversing nerve. It goes down and goes out of this pedicle. Now, what we have done is conceptually, we say that in a functional spinal unit, there are two vertebral bodies with a soft tissue ring in between. And what is a soft tissue ring? In the front, it is the disc here. And at the back, it is a facet joint and the ligamentum flavum, which is interlaminar. So this is a scheme of the thing. And for all practical purposes, to make things more easy to understand, everything which lies above this end plate or the superior end plate of the disc is called as the upper zone. That is this blue thing between the lower part or the lower border of the pedicle to the end plate is upper, above the disc. The red thing or the orange thing is the middle, and the green thing, which is below the disc, infradiscal, that is the end plate of the disc up to mid pedicle, is lower zone. And between this mid pedicle to lower border of the pedicle is a complete bony zone. That is, all the walls are bony. So there are no changes occurring in that area. Now, what is the importance of knowing this? The importance is you will find that the only change which occurs with degeneration is occurring in this middle area or the borders of middle area with the upper zone and middle zone and the lower zone, okay? There are no primary changes in the bones as such. This is a very, very simple fact which we have forgotten. All the clinicians have forgotten that things do not happen in the bone, especially after the age of skeletal maturity. The bones do not change. Okay, they have the same shape, size, etc. Maybe because of porosis it will change, maybe because of fractures it will change, but mechanically they do not change. So this is a very important, simple concept to be understood. Now, we have published this in 2011, what we call as in vivo endoscopic visualization of pathoanatomy. Now I'll just tell you simply what this is. In the past, we used to depend, and even today, most of us who do not do endoscopy depend on the images entirely. You depend on the images to make a decision about thinking of what I should do, whether I should do this, whether I should do it here, etc. What we did is we stopped depending on the images and we started putting our scope through the foramen at the pathology or the changed anatomy. For example, I put my scope through the foramen and I may put it on the disc, on the annulus. I may go through the annulus. I may go inside the disc. I may put it at the annular tear. I may put it above the disc, but towards the head, that is the upper zone, and look at the dorsal root ganglion. I may put it in the lower zone and look at the lateral races, etc. So when we started looking at it, and when you have the patient who is completely awake and aware, the whole world changes. I mean, you must remember that if a patient is awake and you are looking at this structure, for example, here, and you press this structure. When you press the structure, the patient tells you that the pain is going down my leg and it is on my shin. Okay. If you press here, he will say that the pain is going down my leg and going to my big toe. If I use laser around that area, the patient tells me that my big toe is becoming warm. I mean, patient is awake, completely awake. The patient is aware of all those changes. So what we have highlighted here is that in vivo, that is when the patient is awake and aware, we have put the scope and we have understood what it means to have that altered anatomy and what symptom generates from that. Okay, there is no doubt about it. There is no conjecture, there is no guessing. It's not like a traditional thinking where you imagine that this herniation must be giving pain on the right side because it is on the right side. But you will find many times that a patient will come with the pain on the left side. Correct? Many times we see this. Or you will find a patient who will have a central herniation which is down migrated, and patient says, I have no pain at all, but the whole seat area is numb. And I have a problem with urination. You know, it's a Kodak venous syndrome. So what we are trying to say here, what we have done is we have understood the anatomy which had changed, and we have correlated that with the symptoms which arise from that change. There is no guesswork. Completely, we are aware what is happening. And there are two things which we have understood. First thing is that in cases of disc herniation, there is a concept called as pain generator. What it means is that is the area where the thing had changed and the body is reacting in the form of inflammation. So when you touch that area, patient says, it's painful. So you say, where? So he says, same what I told you. Understood? Same pain, what I told you, is being generated when you touch that. That is one part of it. Second part is, again, going back here, you will find that if you watch it very closely, this part of the nerve, what we call the root canal, I'm sure all of us know that, root canal, where the root is around the pedicle, there's a groove in the bone, and the root is traveling from the lower part of the disc, that is this end plate, right up to this end plate, or this is called the exiting nerve. This is the traversing nerve, which is entering the root canal. So here is a model in case you want to have a look at it, I can show. So what you're looking at coming out of the foramen is the exiting nerve. And if you look from above, you will find that the nerve is entering the root canal. Now, what we have found is, if you look at the nerve and its origin, all of us know that a conus is around L1, right? After that, it's all cauda. And then these roots, right from the conus up to the big toe, for example, if you're talking about L5 root, the L5 root is relatively fixed, relatively immobile only in the root canal. Please understand this. This is a very simple anatomical fact, and this is very important. What is important? Have you ever heard a surgeon saying that I will operate the patient here and mobilize the nerve? Have you ever heard that? No, we don't mobilize the nerve. We decompress the nerve. The nerve remains there. The path of the nerve, the way the nerve is lying, etc., is all immobilized in that part. So the nerve is immobile there. And this is very important with respect to stenosis. The symptoms in stenosis, which are more of numbness, more related to venous congestion, more related to arterial ischemia, etc., is related to the immobile part of the nerve. And all of you know that in the upper part of the foramen, we have the segmental artery, which is below the pedicle and which is ventral to the root. And generally, in the lower part of the foramen, we have the venous system or the venous drainage of that segment, which is joining the ascending lumbar vein outside the foramen. Okay, so with these basic things, we'll go ahead. Now, quickly, I'm going to tell you, I'm sure all of you know, but I'll just highlight what this is, our thinking of the thing. Now, a patient comes to me with back pain, which could be like this, vertical, or like this, horizontal. Commonly, I've seen this vertical is because of L4-5 lesion, horizontal is by L5-S1, and this is commonly because of posterior annular tear. Now, don't ask me how do I know. I already told you. I put my scope in the tear and I probe it and I ask the patient, okay, tell me what's happening. Patient says, I'm getting pain in the back. Where? So he says vertical. Okay, confirmed 100%. There's no question about it. Then if you ask the patient to do this test, Mackenzie's test, that is this moment, you ask the patient to lie on the belly and raise the chest. Okay, when you raise the chest, when you are extending the spine, what we have done is we have seen this happening in a intra-op MRI. You put the patient inside the MRI machine. You stand inside the MRI machine, which has got two donuts. Patient is awake. You ask the patient to extend the back. What you actually find is the nucleus moves ventrally and you decompress the posterior annulus naturally. The same thing you can see during endoscopy when your scope is inside the disc and you're asking the patient to cough or sneeze or raise the shoulder, you find the annulus falls down, the nucleus moves in the front. So what happens with this Mackenzie's test is there is a centralization of the pain. What it means is the pain is in the periphery, in the leg. Patient does this and says the pain is coming in the center. Or the patient has pain like this or like this. And when you do this, the patient says the pain is coming to one spot in the center at lumbosacral junction. When he says there is a centralization, it means that there is a tear which can heal on its own. You don't really have to meddle with it. So what you do is you give medical treatment, these exercises, and you do give an intradiscal injection of any anti-inflammatory substance, which could be steroid, could be platelet-rich plasma, could be ozone, whatever you like. Now, if the pain is not centralizing, then you do a MRI nowadays, or in the past we used to do a discogram, or you can say a checkscopy, for example. You put the scope and see, and you will find there is a fragment in the tear, which you remove. There is no fragment, then you treat it conservatively without surgery. So this is for the back pain. This is a very simple algorithm. Ask the patient to lie on the belly, extend the back, look for centralization. If yes, go for non-operative care. If no, think of imaging, then decide depending on the finding in the imaging. Now on the side, if the pain is like this, on the side, which is spot pain, bilateral, and commonly if you ask the patient to show me the pain, the patient will show with the thumb like this. He will not show with the palm of the hand. He will not say the pain is like this. Okay, you understand? He will show like this, not like this. So the facet pain is commonly on the side of the spine. It is well localized, and this pain increases with extension. Okay, with Mackenzie's, you do this movement, and the patient is, the pain is increasing. So you say, where? So he says, going down, coming in the front, whatever. It moves, increases in its extent. So pain increasing with extension, pain increasing with rotation. Many patients will tell you my pain increases when I turn in bed. That again facet pain. So in that case, you give an injection around the facet or you do a facet denervation. So I'll tell you what exactly we mean by that. Now, in case of back pain, we know that this is the sinovertebral nerve, which is supplying the posterior annulus. There is the dura mater. This is the exiting nerve, this is the dorsal root ganglion, this is the traversing nerve going below the lower pedicle, this is upper pedicle, the same like the previous diagram which I showed you. And this area where the sinovertebral nerves are there, this has a dual innervation. It has a sympathetic part of it. It always also has a somatic part of it. So what happens is there is a inside out annular tear, that is a tear of the annulus starting inside the disc coming out. What is the importance of that? In a traumatic tear of the annulus, it is outside in. A tear which is from outside can heal because the disc has a blood supply outside, whereas there is no blood supply inside, so the tear does not heal. It continues to progress and the patient continues to have back pain. So annular tear gives inflammation, then gives chronic dysfunctional healing, granulation, etc. And what we have found is two important things. Pay attention. Number one, in younger people aged around 30, 35, this is a very, very common problem. People have severe back pain, chronic. Most of the people are unable to diagnose them, and they have a chronic annular tear with trapped nuclear fragments in the tear, giving chronic inflammation. Now, in case of facet pain, as I've shown here, the patient will show by finger. This is the medial branch of the dorsal ramus. You can see this is the dorsal ramus, which has got three branches: the medial branch, the intermediate branch, and the lateral branch. And the medial branch lies in this groove outside the pedicle, and the medial branch continues here on the medial aspect of the facet. So when you're treating the facet by innervation, we are supposed to treat at two levels, because one nerve will cover the medial part of the facet, one will cover the lateral part. So if I want to treat this level, I treat it here on the lateral side, and this nerve will come here. So I treat this level here. So two levels, and commonly facet problem is bilateral. So you treat 4 points, but this is done at the local, under vision, and you can easily do it in about 10 minutes per level. So it takes about 40 minutes to relieve the back pain completely, which is coming from facet pain. Now, leg pain. Leg pain could be patchy, could be full. What I mean by patchy is we have found that lateral aspect of the knee here, parapatellar, infrapatellar, posterolateral of the knee, is very, very common complaint in our country. And the commonest problem is the patient says, I cannot sit like this for more than few minutes. The moment I sit like this for more than 5 minutes, I must make my knee straight. Otherwise, it is terrible. Very, very painful here. So this pain, which is on the lateral aspect of the knee or leg, is commonly from L5. In fact, the first indication of L5 pain is the lateral aspect of the knee pain. This pain, if centralizes, that is, the patient does extension and this stops and the pain comes here in the back, and you give a distal block, I'll tell you what this means, and the pain goes away immediately, then you know that this can be conserved. Pain centralizing on extension and relieving, getting relieved by injection distally. What it means, I'll explain within a minute. So this you treat conservatively. Now, if the pain is at the back of the leg or the heel, it is commonest is S1. Now, all the heel pains which we have been talking the past of plantar fasciitis, etc., is all bakwas, nonsense. It is always S1 related pain. You start looking for it, you'll realize what it is. If it is not centralizing and the distal block is not helping, the SLR is positive, there is a neurodeficit, and the MRI or the discogram shows a fragment, go for this transforaminal surgery where you have a stitchless access and there is no fragment, then you think of treating it conservatively. Now, this distal block I have published under this name, sciatica detection and confirmation by new method. Now, what is it? What we have found is when we started seeing patients of sciatic pain, we started feeling the sciatic nerve from the greater sciatic notch right up to the ankle. Feel it, palpate it. And you will find there are 3 areas of the nerve which are extremely painful when the patient is symptomatic. One would be maybe around the ischial tuberosity or behind the trochanter. Second is around the head of the fibula, common peroneal nerve. But important is these 2 points. Point number 1, point number 2. This point is the end of the end of lateral terminal branch of deep peroneal nerve. This is here. I can show, I don't know, maybe difficult to show, somewhere here. You can see it here actually. There is the left foot, there is the anterolateral aspect of the ankle, and that is where the end of lateral terminal branch of deep peroneal nerve is. If that spot is very, very painful, then rest assured that a patient has L5 nerve, L5 root, which is inflamed. And this part is the sural nerve, which is the lateral wall of calcaneus. just at the upper edge of the calcaneus between the tendoachelis and the fibula. Now, I can tell you that if this is tender, it is 100% because of S1. If this is tender, most probably it is because of L5. So what I'm going to say is, if a patient comes to you and says that I have pain in the knee, not here, but here, you feel the nerve here, and the moment you push this nerve, the patient will say, this is painful, but this pain has stopped. Then what we do is we have found that this pain, because of disc herniation, is because of nucleus pulposus acting on the nerve, giving rise to upregulated sodium channels in the nerve. And you know that local anesthetic is a sodium channel blocker. So if you inject sodium channel blocker here, now this structure is called as sinus tarsi. This is the tunnel between talus and calcaneus. You inject 3 cc of 2% plain lignocaine without adrenaline, or you inject lignocaine here, the pain will immediately stop. You have to do this to believe me. I've been doing it for the last 24 years, so I know exactly what I'm talking. In fact, I've published this multiple times. So this is something which will confirm that the pain is inflammatory because it is a tender nerve. You can relieve it by injection of lignocaine, plain simple. And if the pain is relieved and on extension, the pain is centralizing, this big group is to be conserved. These people do not need surgery. They almost always get relieved with non-operative care. Now, what is the use of this? The use is, there is a stage first called as mechanosensitization of the nerve, where the nerve has increased sodium channel proportion, which is detected by my sign. This is my sign. Number 2 is compression, which is because of disc herniation, the mass of herniation, which we commonly have been detecting by straight leg raising. And number 3 is a deficit, which we detect by neurological examination, sensory and motor reflexes, etc. In addition, of course, in case of stenosis, we also do post-void residue of urine on ultrasound to find out whether the bladder is involved. Now, here I must also tell you that when you get a disc herniation, how do you decide whether you would operate that? Is it only on the size? No. You must remember that the disc herniation, the herniation is of 3 types. Type number 1 is pure nuclear herniation, where the piece of nucleus comes out. How do you know that it is pure nucleus? You see the texture on MRI of the center of the disc and the piece. It will be similar. Okay, exactly similar looking, which means it's pure nucleus. Second would be a darker thing, that is a piece of nucleus with dark around, which is a nucleus plus annulus. And the third type is there is nucleus plus annulus plus a fractured piece of end plate. Now, so these are the 3 types of herniations. And the free nuclear piece almost always dissolves in about 2 months' time. You don't have to operate it. I can tell you, leave it and it just goes away. Macrophages eat it away. Type 2 will take about 6 to 8 months. Commonly, it may not go away. And type 3 will take about 2 years, may not go away. Now, see, there is a very fallacious argument in the society, which we all of us commonly come across with the patient. Patients say, but I heard that this can go away. So you should say, yes, completely. But it may take 2 years, okay, the type 3. And you should say that if you want to wait, there is no problem, but it is uncertain. Now, there are some people who are clinicians who would say, but you know, at the end of 2 years, everything is same. I say, no. What you achieve in 2 years, I can achieve in 1 day. Okay, so that's the thinking about it. Why do we operate? We operate because the biological process, the natural resolution of inflammation may not be predictable. It may happen, it may not happen. There are so many factors. So you tell the patient, if you're improving over the last couple of days, weeks, you wait. If you're not improving, consider. Why? Because this looks like a type 3 herniation or a type 2 herniation, which is not going to go away. It may be longer. And if your activities are important, if your earning is important, etc., you think of surgery. We can relieve you almost immediately on table. Now, in case of stenosis, what we do is this is a 10-question questionnaire, which is administered to the patient. The patient fills up this thing. The first 2 answers, yes, is indicative of a mild stenosis. First 6 answers is a moderate, and all 10 answers being yes is a severe stenosis. And you can see the last question, that walking nearly causes urination. This is a very important question, and the patient will volunteer this. I can tell you, I had a patient, male aged 21. He says, sir, I go to the college, but it's so embarrassing. I said, what? He said, you know, if I walk about 50 steps, I must go to the toilet. Otherwise, I'll wet my pants. I cannot bear this. So things do happen that way. You have to be aware of that. And in all these patients, you must do a post-wide residue. Now, what is this idea of doing post-wide residue? You must be aware that all of us who operate on spine, in the past, it used to happen that you see a patient, you advise surgery, you operate the patient, and unfortunately, the evening of the surgery, patient says, I cannot pass urine. So you say, okay, no problem, I'll pass a catheter. But in your own mind, you're worried whether you have damaged something, whether something is done which should not have been done, etc. More so when you're operating the patient under general anesthesia. You don't really know, you're pulling, pushing. So here you do a post-wide residue. You know, I can tell you in my practice, 18% patients have a high post-wide residue in males above 100 cc, in females above 60 cc. So if a patient comes to you with a high post-wide residue, you tell the patient, you already have a neurogenic bladder. I mean, in males, you also know that there could be prostate, but after ruling out the other thing, you say that this could be because of detrusor underactivity, and this may worsen for a short time after surgery. You better be prepared. And I always tell all my colleagues that what you speak before surgery is taken as science. What you speak after surgery is taken as defense. Okay, you say the same thing after surgery. You are going to say like that because you have damaged my bladder. Now you compensate me. It's a terrible situation, completely avoidable if you do this test. Now, in case of stenosis, you have to remember what is actually happening is happening in this area, the axilla. Okay, the nerve which is going out, the nerve which is inside, and this area is compressed. There are multiple theories, but I can tell you after going through multiple papers, the conclusion is very simple. It is venous congestion more than arterial ischemia. And this venous congestion, you must be aware in our patients, for example, almost all patients will tell you that they are little better in the morning when they have stenotic claudication after evacuating. When the bowel is empty, they feel, oh, I'm much better. My legs are much better. That is because the Batson's plexus and intestinal venous drainage is connected. So when the pressure there is less, the patient is naturally better. Now, this is a matrix which I have published. I'll tell you what it exactly means. There are 6 symptom groups. Okay. I'll quickly tell you what has happened is when I was a student in 1980, when I started my residency about 40 years back, I was told by my teachers that, you know, you cannot diagnose 65% of the patients. And we used to believe that. I mean, there was no MRI in those days. We only used to do a myelography. And we used to ask the patient, what is your problem? He's here, whatever. There was no correlation of pain or symptom, image, pathology. So everything was all guesswork. And it was a complete mess in those days. So we were told that you cannot diagnose more than 65%. Now today I can tell you that I can diagnose almost all of them, and the symptoms are only finite 6 groups, nothing out of it. Okay. The first is knee pain, heel pain, groin pain, and coccygeal pain. Now, groin pain and coccygeal pain are S1 related pains. Please mark my word. I have seen hundreds of them. Almost all who come to you with groin, of course, I'm not saying it can't be because of hernia, inguinal hernia, but I'm saying you have ruled out the standard causes. Then the patient has groin pain. Or the patient says, you know what, when I sit erect, there's no pain. But when I slouch, I get pain here, the coccygeal area. That is classic L5S1 related pain. So that is the first group. The second group is low back pain because of facet, which I told you is paraspinal, well localized, increases with extension or rotation. You can treat it simply by anti-inflammatory injections or denervation of the facet. The third is low back pain, which is axial, either vertical or horizontal, discogenic, because of chronic posterior annular tear with trapped nuclear fragments in the tear, giving rise to chronic inflammation. And I can tell you that if somebody of you decides to entirely concentrate his career on this. Number 3, back pain in younger people aged around 30. I can guarantee you within 5 years, you will be a billionaire. The number of patients suffering is so huge, unimaginable numbers are there. And what is happening today is because most of us are all fascinated with the images, and the dumb image people tell us that, you know, the outline of the disc is normal, except that the disc is black. They don't know anything. Okay, please do not believe the image space. They have never ever examined a single patient in their life. They have never treated a single patient in their life. What right do they have to talk like this when they don't know anything about it? So please remember, a low back pain in a young person, 30s, whereas the first complaint which I told you generally in the 20s. You must have seen a lot of young people, adolescents coming with pain around the patella here. It is not chondromalacia, okay? It is sciatic pain. It has started, L5 has started. Please remember this. I mean, look for it. You will find it is there. Number 4 is plain simple sciatic pain of L5 or S1, classic side of the thigh, here, and going up to the big toe, back of the thigh, back of the calf, in the heel, going to the lateral 2 toes, etc. Then 5th is claudication, which is because of a stable spine. That is, the spine is stable. There is no instability whatsoever. Maybe there's a micro instability. And point number 6 is claudication in the unstable spine. That is where you have a listhesis, which may be degenerative, which may be lytic listhesis, whatever. So apart from this, there is nothing. Okay. Now, how this will help you is that when the patient comes to you, don't get overwhelmed by what the patient is talking. You must remember that you already have a plan in your mind where to fit him. He cannot be outside this. He has to be knee, heel, groin, coccygeal pain, back pain, paraspinal well localized, back pain, vertical, horizontal, sciatic pain, where you feel the nerve and confirm L5 or S1 or SLR or whatever, or claudication, where the patient says my pain increases when I stand or walk. I cannot walk beyond this. I cannot stand beyond this time. And there may be bladder affection in that case. And you do an X-ray and you find that the spine is stable or the spine is unstable. So now you know there are 6 categories of patients to be treated. So what we have done is we have achieved this. From this surgery, this is my surgery. In this patient who had a recurrence, I operated through this incision. Now, if somebody tells you that I have done endoscopic disc surgery from this incision, you won't believe it. I mean, commonly, you know, now you're a surgeon, so you would know it. But we have had a lot of fights with the insurance people where they say, how can you operate? I say, are you asking me a question or are you showing your ignorance? I mean, you don't know anything. You please come and have a look what we do. So this is what we do. Now, when I started in 1999, I used to call this surgery as minimally invasive spine surgery. But what happened is everyone said that I am also minimally invasive, and they just made their incision little smaller. So when they were cutting 70 millimeters, they started cutting 69 millimeters. And see, I'm minimally invasive because yesterday it was 70, today it is 69. So I say, okay, I have no quarrel with you. But I changed the name of my surgery into stitchless surgery under local anesthesia. Now, these 2 features nobody can match. Okay. So this is open surgery, open discectomy or microlumbar discectomy, where you would agree that there is a big incision on the skin and comparatively the working area is smaller. So this is like a cone. Now here, this is a micro endoscopic discectomy, whatever. I mean, I call it a pseudo minimally invasive surgery where the skin cut is smaller, but everything under the skin is as big as open surgery. Let us be honest about it. I'm not criticizing. I'm not saying this is bad. I'm saying this is the reality. You are just fooling the patient by saying the skin cut is smaller. Okay, no problem. So this is like a tent. This is like a cone. This is our surgery where we cut the skin and we cut the annulus. In between, we just dilate the muscles. I mean, there is no cut, nothing. So the moment I remove my instrument, it just heals. So 24 hours later, you will find the skin is sticking. You don't need a dressing. You don't need a stitch. And the muscle has just been dilated. So the moment you remove the instrument, it's all fine. The patient can be up and about. So this is the true non-morbid transforaminal endoscopy, which is the real minimally invasive. Now, just to orient you, this is a dissection where you see this is a laminotomy, this is the midline, this is the right side, this is the pars intraarticularis, this is the facet joint, this is the exiting nerve, this is the traversing nerve which goes down and comes out of the lower foramen. Okay, this is the dural sac. Now, if we look at it, this is our surgery where we put the scope below the pars or below the facet, which is always in the axilla of the exiting nerve. Okay, let me say this again. This is the exiting nerve. So I land here. I am always in the axilla of the exiting nerve. There is no confusion in my mind whether I'm on the shoulder or in the axilla, etc. And when I teach my colleagues, I tell them that when you're operating on the left side, look at your own left hand like this. The thumb is the exiting nerve, the index finger is the traversing nerve. You're always here. Always here in the first web space. And the metacarpophalangeal joint of the thumb is the dorsal root ganglion. Okay, so it's always like this here in the first web space. For the right side, you see like this. Very easy to remember, very easy to visualize. Now, why do you need to visualize? Because you're not cutting anything. Okay, you're putting your scope more or less blindly, more or less. And then when you put the scope, you start seeing the whole world. So till you put the scope, everything is by guess, now that is, there is a method in it. Let me tell you one more thing, that all our teaching all these years have been by trial and error. I don't like that. I say that why should there be a trial and error? Have you ever seen a jet or a bomber going to the enemy territory saying, okay, let me try whether I can hit this target? No, I mean, it is foolish. So like that, our surgery is extremely precise. My surgery has a precision of 1.2 millimeters. That is the width of the needle. Okay, so I can put the needle exactly where I want it to be. That is the key to the whole success in this surgery. After I put my needle, then I do certain maneuvers, which I'll show you within the next couple of minutes. Then this is the way we come. So we are paraspinal, about 12 centimeters from the midline. We are intramuscular, we are retroperitoneal, and we are below the.
They call him Superman in China.
So this is a. So this is a transforaminal surgery. This is under local anesthesia. Patient is completely awake and aware. And I have just put in a clip here, which you can see on the left is a microdiscectomy, and on the right is a endoscopic surgery of the same patient recorded at the same time. Now, I would like you to concentrate on the left. There is a little delay. Okay. So what will happen is you see something on the left. Now this instrument going in and trying to get a piece of the disc. Then you will see it on the right there. Okay, here. Now this is what was happening here. On the left is a view from posterior midline, a microdiscectomy. This is a view through my scope. Now here I'm not irrigating my scope at present. So this will look bloody. As you know, the disc is avascular and aneural. So there's no pain, there's no bleeding ever. But here, now see, I started irrigating. Now this probe, which I put through the annulus, is seen here through the scope. This is seen through the endoscope, where the dorsum is 12 o'clock, ventral 6 o'clock. This is toward the leg, toward the head. Here, this toward the head. This is midline, this is lateral. Now you can see the irrigation, which I'm putting through the scope coming out from here. Now here, what I'm going to do is I'm going to put this probe. You can see this. This is above the annulus here. And now see here, this is above the annulus. That's the tip of the instrument there. Now I'm going to use a cautery here to shrink the annulus. I'm going to use an annular cutter to cut the annulus and have a look. See, now I'm withdrawing my cannula so that I can have a better look. Now see, this is an annular cutter, and you will see the tip of that instrument there when I cut. Okay, can you see that? So what I'm trying to show you here is I'm doing the same surgery which you do as a microdiscectomy, but I do it under local, I do it under irrigation, it is bloodless, it is painless, and the patient is talking with me throughout the surgery. And there is nothing like this, no charring, no cautery, no nothing. So, I mean, this is not a sales pitch. But there is a simple comparison that you see this and you see this. I'm using the bipolar cautery under irrigation on the edges of the annulus, etc., etc. So this is the distinction. And there are many more comparative sort of videos which we have. So this is a hook which I put there epidurally, which you'll see here now. You see the tip of the hook there, which is a blunt instrument, and I can mobilize the fragment, etc., etc. Now here, this is a good indication to me. The oozing which comes from outside, inside the disc means that I've cleaned that whole thing from inside. And please understand that all disc herniations start from inside. Okay, there should be no argument on that. I mean, herniation will start from inside and go out. It will never come from outside. So our surgery is more physiological. We are at the place where it has started. We are working on the base of the herniation, which could be like an iceberg, where the tip may be small, the base may be big. So in short, this is a comparison. Now, what we found is, like, as I said, we do the post-void residue. That started with a question in one of our conferences where somebody said, you know, sir, we have so many people who have post-op retention. Can we not predict something? Can we not do something? So we started doing post-void residue and we found that correlation. Here, what we thought is, most of us, when we operate the disc, we do an annulectomy or we take a cruciate incision, etc., and we leave that open. Correct? We don't close it. So we close it. Now this is a platelet-rich fibrin plug. How this is made is very simple. You take 15 cc of blood from the patient, put it in an AP tube, autoclaved plain tube without anticoagulant, put it in a centrifuge. The centrifuge is called a doctor's centrifuge. It costs about 6,700 rupees. Centrifuge is at 3,000 RPM for 10 minutes. At the end of 10 minutes, leave it for 10 more minutes. At the end of 20 minutes, this is what you get. Now here, if you watch carefully, all this yellow is platelets. All that red is RBCs, and there is a line in between called as a Buffy coat. That is where the WBCs, etc., are situated. So remove the RBCs and put that whole yellow thing down the tube inside the disc and plug it. So what we do is we close the opening which we have made in the disc for the surgery, and we also close the tear, which is the original tear, which is causing the symptoms. And this changes the post-op pain drastically. I mean, after this patient hardly needs any painkiller post-op. And this also stimulates healing because the platelets carry a lot of growth factors. And we are doing a lot of work in Pune in National Center for Cell Sciences and a tissue culture lab, where we would probably come out with a biological solution for healing of the annulus very soon. Now, this is the skin cut which I have, which is around 8 millimeters. Now, I'll quickly tell you about stenosis because there is a lot to talk, but I'll just quickly tell you. Now, you look at this picture. What is this? This is, in short, image where I have removed the body of L5. Okay. So what we are looking at is looking from ventral aspect. And this is the pedicle. This is the body of S1. This is the superior articular process. This is the inferior articular process of L5. This is the superior articular process of L5. This is the lamina. This is the lamina. This is the interlaminar area, etc. Now, you must remember that the nerve is coming down and going out of the foramen below the pedicle here. Correct? So that upper zone, which I told you, is actually above the tip of the SAP. So you draw a line from here to here. Whatever lies proximal or cephalad is upper zone. Now here, please remember that in the upper zone, this lamina is not in touch with the dural sac. It is away. Correct? It's sloping away. And here it is complete bone. You must be aware that the interlaminar ligamentum flavum is attached to the ventral surface of the upper lamina, correct? So when we do open surgery, we find that the ligamentum flavum will start somewhere here and go down, go distally or caudal. So this area, there is no cause which can cause a compression of the dural sac. Nothing. here what happens is there is something which all of us have ignored, which I'm going to show you, is a new finding multiple times, and we have seen it hundreds of times, is the lateral part of the ligamentum flavum. Now, let me tell you that we classified like this. There are 3 zones, which I told you. The upper zone, supradiscal, middle is the discal zone, infradiscal is the lower zone. There are 3 causes only. First cause is disc and its margins. Second cause is facet and its margin. And the third cause is ligamentum flavum. Apart from this, there is nothing. Nothing changes. Only these 3 things change. And there are 3 walls to be looked at. The anterior wall, the body, the posterior wall, commonly the lamina, and the lateral wall, which is ignored by the open surgeon, that is the foramen, where we land. Okay, the axilla, and we land under the root, etc. So we are dealing with 3 zones and 3 walls, and we do a lateral decompression in case of stenosis. Now, please mind this point, that this bone and the bone below, or let's say this bone and this bone, we actually have no business to cut it. There's no reason why it should be cut. It is cut because traditionally, as a legacy, we have been told that interlaminar access is the standardized access. If you ask me as an academic question, oh, I'm sorry.
And then we can go ahead and see the endoscopic and lateral base anatomy. I hope every one of you saw the basilar anatomy. Everyone saw? So we will see the MOCR, LOCR, everything is ready right now. We'll go down to the paraclavian region also. Dr. Gore, you can take another 15 minutes more. And I'm so fascinated by the things that you are saying. I mean, I don't do any spine at all, but you are doing. Yeah. No, but it's amazing how you made that that Buffy that fibrin rich. We've been trying to do that so much time for. We have published about it. We have been doing it for almost 7 years. It's amazing, what we are really blessed with is these chaps yesterday. Those guys who came in, this is a land of innovation. It looks like, so. You have people like us, like Professor Gore, who comes and innovates so much. I mean, we would like to definitely learn this from you, how you have done this thing. We can use it in skull base. Yeah, definitely. Because we are using TIS-seal and things, very costly things, fibrin glue and all that. Yeah. So if we can use it in skull base as a sealant.
Definitely you can use it, and it doesn't cost. Actually, we did the costing. It costs 8 rupees. Nothing.
Yeah, so we really would definitely like to learn this from you. How, sure. Nilesh and Trishant, will you please take notice that we will go to Pune and then we will learn how this is done. Okay, so that we understand how we can start it in skull base. Okay, thank you so much for coming down. And okay. I mean, I just came in and I was listening. It's fascinating.
Very good.
Yeah,
thank you.
Thank you so much.
Okay.
If you can announce that in a batches of 5, they can come and see the anastomosis and have a look at the existence. Okay, after that, in batches of 5.
So what I was telling you is we are looking at the ventral perspective. So for a second, just forget that you do interlaminar surgery. Okay, you are just a beginner and you have never done any spine surgery and you are just going to start it tomorrow. So I'm telling you that you're looking at the ventral perspective. And now here, this is a plane which is at the lower end plate of the upper vertebra or the upper end plate of the disc. So everything above this will be the upper zone, everything between this and the end plate will be the middle, etc. Now here I have done some cadaver dissection, which I have a long video, but I'm just going to tell you something very simple. What I'm holding is the upper part of the annulus, and this is the superior foraminal ligament between the tip of the SAP and the pedicle above. And this is a very important structure when stenosis is being treated. I'll show you a couple of more things now. So what we have done is we have extended our system into what we call as channelplasty, and where we go for the roof of the canal. Okay, please remember, we are not operating the disc now. We are operating the roof of the canal. And I'll show you a thing or two within 2 minutes. This is what we have as a perspective when we do open surgery. We have the root going out, the second root going out is the axilla, and then this is the pedicle, the disc, etc. And this image is very clearly understood by everyone. But please remember, we are not looking from dorsal side. We are looking from the ventral aspect. Now here, the upper zone is marked, the middle and the lower. And for the foraminal perspective, this is the upper, this is the middle, this is the lower. Now, this is the upper zone, that is here, okay? This is the model which has been pictured there. So you can see here, the lower vertebra, the upper zone is being seen from below, correct? So we see the dural sac, we see the exiting nerve here, we see the dorsal ganglion, and the only thing which can give stenosis in this zone is a change which occurs here under the pars, which could be a lysis, which will give rise to reparative tissue at the pars or the spondylolytic defect. Second is the ligamentum flavum, which is lying there, which I'll show very soon. The third is the osteophyte, which comes up here, very common. Osteophyte at the lower end plate of the vertebral body, which will push the nerve up. So these are the three causes in the upper zone. There is nothing here, no cause in the center at the posterior aspect. There is no cause here because posterior longitudinal ligament is there. Now here, this is the upper zone. Of course, this is upper lumbar spine, but you can see there is the lamina, there is the ligamentum flavum, this is the posterolateral corner of the annulus, this is the inferior articular process, this is the dorsal ganglion, and these two margins are actually the foraminal area. So what we are trying to convey to you is that you can easily treat the causes of stenosis in the upper zone through the foramen. Now this is the lower zone. Lower zone is below the, this orange thing which you see is the disc. There is a herniated part in the model here. And what we are looking at is below the disc. Now this is a very difficult zone to tackle. And what we have been doing in open surgery is we have always been doing for all patients, we have been doing a medial facetectomy and probably removing the part of the facet, etc. And unfortunately, it breaks down, and then you justify putting screws and all that. Now, that is not very correct. It is academically not correct because you don't even know where the cause is. And many times the causes are ventral to the nerve. So this is same, this is the lower zone that is inside the pedicle here, where the nerve is going out. And this is what it is. This is the pedicle just below the pedicle. So ligamentum flavum comes up here, and these are some venous channels there, spinal nerve here, etc. There is no nerve in the lower zone. Okay, the lower zone, the foramen, there is no nerve, but there is a nerve which is medial to the pedicle. Now, please look at this. This is something very important. This is a 3D fusion imaging of the ligamentum flavum. And what you're looking at, this yellow thing, is the ligamentum flavum. So naturally, it's not something which is horizontal and interlaminar. There's a horn-like thing which is going up. And please look at this. This horn-like thing goes and compresses the nerve, and this black circle is the pedicle. So in the upper zone, this is the lateral part of the ligamentum flavum. Now, how do you know that this is involved? What you could do is you could ask your MRI specialist to do this image. This is my publication on coronal oblique imaging. It is very simple. You tell the MRI specialist that you want a coronal oblique protocol, which is used for sacroiliac joint. It is already there in that MRI machine. Coronal oblique protocol, SI joint for lower lumbar spine. And then you will find this image, this black thing with that blue arrow is the ligamentum flavum, which goes from the midline right up to the pedicle above, which is what we are talking about, this. Okay, and the blue arrow shows you the portion which is below the facet joint, and everything between the blue arrow and the pedicle is the one which we need to remove if it is causing stenosis of the exiting nerve pathway. Now, this is anatomy of the true anatomy of ligamentum flavum when seen from ventral aspect. You can imagine that the ligamentum flavum is not only from here to here. It is going out in the foramen. Okay, as I say, it is not this, it is like this, going up. So this lateral ligamentum flavum, which is here, which is below the pedicle, is what causes the stenosis in the upper part of the foramen. And remember, this part in the middle is quite deep. It is not in one plane. It's a deeper structure, the midline. And in the midline, you know, the ligamentum flavum is not combined. It is separate. There are two different slips. The other important point is at the lower attachment to the ligamentum flavum, it is on the edge of the lamina. And on the upper attachment to the ligamentum flavum, it is below the upper lamina, ventral to the upper lamina. That is why in open surgery, you do a little laminotomy of the upper lamina, expose the ligamentum flavum, then come down, then go to the medial facetectomy, etc. So here what we are saying is, this part is important in the upper part of the foramen where the root is going out. Now, I'm going to make a very important statement. Please pay attention carefully. There has been a lot of talk of central canal stenosis. Okay, there is nothing. We have been made to believe that central canal stenosis is pressure from behind. Completely untrue. It is always pressure from both sides. So I call it, there is a pincer. These are two facets which are compressing the ligamentum flavum. I'm sorry, compressing the dural sac. I'll show a couple of images here. Now, there is another paper which talks about the ligamentum flavum. It is like this, commonly believed to be, but this is what is seen in only 2%. And this is type B and type C, where it goes under the facet, goes up to the pedicle. And this is the only paper in the literature which talks about ventral dissection of the ligamentum flavum. Please read this. This is in European Spine Journal, published by an author named Okuda, O-K-U-D-A, ventral dissection. So here, what happens is there is a central, there is a subarticular part, there is a foraminal part, there is an extraforaminal part. So this is the ligamentum flavum, this, not in the center. Now this red thing which I have marked is the ligamentum flavum. The one which is above the SAP, now this is a ventral dissection. Remember, we are not looking from behind, we are looking from the front. So this is the dural sac, and there is a hypertrophy of ligament here and here. This is what causes the central stenosis. The ligamentum flavum growing on the medial face of the facet, not the posterior midline. So here again, in the upper zone, this is the SAP which we cut. And the important thing is, after cutting this SAP, we go around it. That is, we cut the SAP and we go around it like this to the central part of the canal, and we remove that ligamentum flavum. So you must be wondering, how can it be done under local? How can you do it? I mean, we are doing it every day. So this is what it is. Now, this is a patient, as you can see marked here. This is upper zone hypertrophy. This is both middle zone, and we have these curettes. This is the curette below the facet or the tip of the facet here. And this is the way we remove. Now, this is a cadaver dissection. This instrument is in the facet joint. This probe is in the foramen from outside. We are looking at the foramen from inside. That is from medial side towards the lateral side. And this is the way I look at in my endoscopy. This is the nerve, exiting nerve. This is a laser probe. I use laser here and remove this ligamentum flavum. And here I remove the tip of the SAP so as to go around it for the central canal. This is the ligamentum flavum, which is inside. And this space is normally occupied by the bone here. On the left is the axilla. Okay, on the left side is the head of the patient and the axilla of the patient. So now I'll repeat that statement. You see, this is the facet, the V of the facet, and just see the gradation. Now here, tell me, do you think that this image is showing you a compression from behind? It's not compression from behind, it's from the sides. Okay, so posterolateral compression of this V like this and not like this. So this can be treated from both the foramina. Okay, we can go biportal, and I can treat central canal stenosis very well by going biportal. So this is what I've done in one of my patients, where I've done this undercutting of the facet, where I've seen that there is a gross increase in the volume of the foramen. And this is final one or two slides maybe. This is the lower zone, which is below the disc inside the pedicle. So this is where it is. This is the lower end plate of the disc, and we work here. Now, let me tell you that this particular structure is how many millimeters from my landing there, you think? It's probably less than 6 millimeters. Okay, it is just there next to me. So don't imagine that you're operating in a football field or something and it's so much away from you. It's just there. The only thing is you have to visualize it better. Otherwise, you won't understand. So here, what I've done is I put my scope here, and very simply, I'll tell you, this white arrow is showing the nerve going inside the lower zone or the lateral recess. This is the pedicle below, which is climbing up this superior articular process. So this is the nerve which I decompress, and this is the decompression for the lower zone. So what I do is, this is a coronal perspective. I work inside the pedicle here, or I work inside the pedicle here. I put my scope here in the foramen at the lower end plate, and then I start from the lower pedicle, go up SAP, cut this, make this big. I may do a medial oblique pediculectomy and decompress this nerve so that this nerve which is coming in this lower zone is completely decompressed. This surgery is here, as we see from inside the canal. It is here on the shoulder of the nerve. And if you remove the upper bone here, you will find it is here where the nerve is entering the root canal. So in short, this is the gist of what I do. And I think I've tried to convey to you what exactly is possible. Now, I am doing it for the last 20 years. Stenosis, specifically, I'm doing for the last 5 years. We have all the equipment to do all that. And as for your time permitting, once you finish that, or now for another 5 minutes, if organizers allow me, I'll just show you the instruments and then you can go for your surgery. Okay. So quickly, you just sit here. I'll bring the instruments here and show one by one. That blue tray, yeah. And there is a white model in that red bag. Yeah, so I just want that.
Meanwhile, if anybody has any questions to ask to Dr.
Yeah, please.
Satish Chandra Gore,
Yeah,
please.
please. I'm sorry, I should have. Yeah, thank you.
Sir, nice presentation. As you're talking, you're doing surgeries in local. So I want to know what position and how you give the position and how.
Sorry?
How you give positions.
How we give?
Position.
The position is prone.
Yeah.
And the patient is explained before the surgery what we are going to do. So he is not, I know patients are anxious. They feel terrible. They feel that you do something and something may go wrong, etc. So I tell them, don't worry, we are capable of handling everything. Okay. So what we do is the patient is awake. If he is very anxious, then my anesthetist gives IV midazolam or fentanyl or tramadol or anything of that sort. They also give glycopyrrolate prior to the surgery. I can tell you that patients are anxious, but when you explain to them, they are quite okay. I mean, they can tolerate it. And well, we have done it for the last 20 years, so you can believe me. It's not a big deal. Initially, yes. Initially, I actually put it this way, that surgeon is more anxious rather than the patient, because we feel, oh my God, if patient jumps from table, what will happen?
Do you put bolsters?
Yeah, I use bolsters. There are latex bolsters, and patient is, actually, I'll tell you, I start the surgery. The moment you remove that herniation, takes me about 20 minutes. Patient starts snoring. Patient goes to sleep. You have to shake him. Hello, how are you? Okay, yeah. Okay, I'm fine. That sort of thing happens many times.
Thank you, sir. Sorry to just interrupt.